Hi, this is Eric Zevallos, and today we will be talking about point-of-care renal ultrasound. Before we begin, I have no conflicts of interest nor have anything to disclose. The goals of this lecture will be to become comfortable with the indications for point-of-care renal ultrasound, as well as being comfortable interpreting normal renal anatomy and some abnormal renal pathologies. I want you to be able to assess for the presence or absence of hydronephrosis, be familiar with the definitions and appearance of a normal renal cyst, and lastly, be able to calculate bladder volumes. Renal ultrasound is one of the traditional point-of-care applications which began to popularize the concept of bedside physician-performed and interpreted ultrasound. Compared to many of the other ultrasounds performed, it tends to be easier to master, largely because the kidneys are relatively superficial structures and thus less affected by artifacts caused by air, fatty tissue, and other surrounding structures. You also have the benefit of the kidneys being paired organs, allowing you to compare an abnormal appearing kidney to the other side. Lastly, the renal ultrasound exam becomes very familiar because it is incorporated into many other point-of-care examinations. Similar to the other exams you will perform, you want to view the kidney in two planes, scanning slowly to identify major structures. Always compare the two kidneys to each other, even when no abnormal pathology is initially appreciated. Compared to many of the other point-of-care examinations, the renal exam requires more clinical interpretation, mainly because hydronephrosis is graded and not a simple yes or no binary question, thus leading to a higher degree of clinical integration as well. Scanning patients with hydronephrosis or pyelonephritis can be very uncomfortable and or painful, so pre-treat with pain medication to allow for maximum patient cooperation. The clinical indications for point-of-care ultrasound are broad and include any patient with flank pain, abdominal pain, hematuria, or any urinary complaint. Now, the primary clinical application for point-of-care renal ultrasound is for the detection of hydronephrosis. However, it is commonly used to evaluate bladder volumes as well. Incidental intrarenal stones and cysts are often appreciated as well. Typically, ultrasound is not sufficient to identify ureteral stones. However, in the appropriate clinical setting with evidence of unilateral hydronephrosis, one can deduce the presence of an obstructing stone. In patients found to have bilateral hydronephrosis, you must think about an obstruction distally, such as BPH or cancer. Unilateral compression leading to a unilateral hydronephrosis can also occasionally be seen in pregnancy or in patients with an abdominal mass. Clinical indications and image interpretation varies between point-of-care renal ultrasound and a complete renal ultrasound read by a radiologist. Again, the main indication for point-of-care ultrasound is for the identification of hydronephrosis, while indications for radiology renal ultrasound extend from renal failure all the way to the evaluation for renal or bladder cancer. Radiology ultrasound will evaluate for subtle findings such as bladder wall thickness, vascular examinations of the kidney, and changes in the size, structure, and masses within the kidney. While these findings may be found on point-of-care ultrasound as well, these are not reliably excluded with the point-of-care examination. As mentioned earlier, pain control prior to examination is essential for patient cooperation. Again, the main goal of point-of-care ultrasound is for the detection of hydronephrosis. Dehydration significantly decreases the sensitivity for the detection of hydronephrosis, and often the patients which we are scanning for hydronephrosis are dehydrated secondary to profound vomiting or diarrhea. Because of this, patients need to be adequately hydrated prior to performing the examination. Typically, patients are evaluated in the supine position. Occasionally, they will need to be placed in the lateral decubitus position to optimize visualization of the kidney. When performing the point-of-care renal ultrasound exam, we typically use the curvilinear or abdominal probe. Occasionally, the phased array or cardiac probe can be utilized when having difficulty imaging the kidney between the rib spaces. Just be aware that while using the cardiac probe, the images will have less definition and less overall quality when compared to the curvilinear probe. Some machines will have dedicated renal settings. This is not always the case though, and if absent, the abdominal setting works just fine. The first image you want to obtain should be fairly similar to the image pictured on the right of this slide, where you are able to visualize both the kidney and the liver in a single shot. You then want to adjust the gain so that the kidney cortex is hypoechoic or less bright compared to the liver. Remember that when transitioning from evaluating one kidney to the other, you do not want to readjust the gain, the depth, or any setting on the ultrasound machine. The probe should be placed in the anterior to mid-axillary line with the probe indicator initially facing toward the patient's head, as seen here. This will give you the most intuitive relationship of the kidney to the other abdominal structures, such as the liver, the spleen, the aorta, and the IVC. Begin by visualizing the kidney, and then slightly rotate the probe until the long axis of the kidney is visualized. Then sweep side to side, visualizing the kidney in its entirety. Typically, the long axis of the kidney will not coincide to the long axis of the body. Now, just to point out a little bit of normal anatomy here, you have the kidney right here, sitting adjacent to the liver edge. And this is the tail of the liver coming in here. You have the spine down here, and the diaphragm sitting up here on the left side. These shadows that you see, which obscure some of your view of the kidney, are rib shadows. Once the long axis of the kidney has been fully visualized, rotate the probe approximately 90 degrees in order to visualize the kidney in the short axis or cross-section view. Again, pan from top to bottom in order to visualize the entire kidney. Compare images obtained from one kidney to the opposite kidney, maintaining the same depth, contrast, and gain. Occasionally, the ribs will make visualization of the kidney difficult. If this occurs, have the patient take a deep breath, which will bring the kidneys below the ribs, hopefully allowing for better visualization as seen in this video. Again, you may also try having the patient roll into the lateral decubitus position to aid in visualization. Again, you can see a rib shadow coming down right here, which obscures the superior portion of the kidney, and when the patient takes a deep breath, it brings the superior portion just below the rib. Lastly, you want to image the bladder. The visualization of ureteral jets can aid in ruling out a complete obstruction, while the absence of ureteral jets have to significantly increase your concern for a complete obstruction in the right clinical setting. Occasionally, stones or masses can also be visualized within the bladder. We will now talk about normal kidney anatomy as seen with the ultrasound, and then progress to examples of abnormal renal pathology. The kidneys are retroperitoneal organs which lie lateral to the IVC and aorta. The right kidney is bounded superiorly and anteriorly by the liver and posteriorly by the psoas muscle. The left kidney is bounded anteriorly by the spleen, superiorly by the diaphragm, and posteriorly by the psoas muscle. Normal kidney length is approximately 9 to 13 centimeters, while normal width is approximately 4 to 6 centimeters. The possible causes for an enlarged kidney range from diabetic neuropathy, acute glomerular nephritis, to HIV or leukemia, just to name a few. Small kidneys are frequently seen in patients with chronic kidney disease or patients who are on dialysis. The kidneys are anatomically made up of two parts, the parenchyma and the renal sinus. The parenchyma includes the cortex and the medulla, while the renal sinus includes the renal pelvis and the renal vasculature. Sonographically, the cortex is just deep to the capsule and is homogeneous, while the medulla houses the renal pyramids and is hypoechoic. The renal sinus is the centralmost portion of the kidney and typically appears hyperechoic compared to the medulla. Again, this portion of the kidney is made up of the calyxes and the vasculature. This video panning through the kidney demonstrates the normal renal anatomy, with the parenchyma or outer portion of the kidney being hypoechoic and the central portion or the renal sinus being hyperechoic or more bright. The standard renal exam consists of complete visualization of the kidney in both long and short axis, always sweeping side to side, being careful not to miss any portion of the kidney. The most commonly overlooked area of the kidney is the inferior pole. While panning, note any gross abnormalities, specifically looking for the size of the calyxes. Compare both kidneys to each other, and lastly, visualize the bladder. The primary goal for point-of-care renal ultrasound is for the detection of hydronephrosis. If you remember nothing else about this lecture, I promise it will be that. Here's an example of a patient with moderate hydronephrosis. In this still image, you can appreciate dilation of the renal calyxes and pelvis, as well as dilation of the pyramids. However, notice that the cortex does not appear to be thinned. This is what separates moderate hydronephrosis from severe hydronephrosis. So I've stressed the point that renal ultrasound is primarily used to evaluate for hydronephrosis, but how accurate is renal ultrasound for the detection of renal calculi? In this study performed by Fowler, he found that the overall sensitivity for stone detection was only about 32 to 57%, with the mean stone size which was detected being approximately 7 millimeters large. For stones which were less than 3 millimeters in size, nearly 3/4 of them were missed with the ultrasound. So ultrasound is not very specific for detecting renal calculi. However, when looking for hydronephrosis, ultrasound is highly sensitive and specific. According to this article published in 2004, sensitivity was 93% and 100% specific. This study used CT scanners as a comparison method. The major difference between the ultrasound and the CT results occurred debating small hydronephrosis secondary to a non-obstructing stone. Agreement for severe hydronephrosis was 100%. One of the true benefits of ultrasound shines when looking at CT data for patients with nephrolithiasis and the absurd level of radiation these patients are exposed to. In a study by Katz in 2006, they found that approximately 4 patients with a history of nephrolithiasis have at least 2 CT scans for the evaluation of renal colic, with radiation exposures ranging from 19 all the way up to 150 MSVs. The clinical treatment and workup for flank pain depends on several factors, with the new onset of pain, signs of infection, prolonged periods of pain, and increasing age being the most concerning findings. Given that ultrasound does not expose a patient to any radiation, it makes sense to utilize it as the primary modality in the evaluation of undifferentiated flank pain. By evaluating for the presence or absence of hydronephrosis, it can steer the medical management into the appropriate direction. In patients that are well hydrated and aren't presenting in the acute period, the absence of hydronephrosis essentially rules out an obstructive process. We will now start talking about abnormal renal pathology seen with the ultrasound, starting with hydronephrosis. When the ureter becomes obstructed by a stone or mass, urine backs up into the kidney, causing the renal pelvis to become distended. As fluid accumulates into the renal pelvis, it changes the ultrasound appearance from the typical hyperechoic appearance to a darker or more hypoechoic appearance. As the obstruction worsens, fluid will begin to spread from the renal pelvis to the calyxes and finally into the pyramid, since all of these structures are interconnected. Hydronephrosis is graded either numerically, as demonstrated on this slide, or more simply as normal, mild, moderate, or severe nephrosis, as seen in this slide. Here's an example of mild hydronephrosis. Notice the slight dilation of the renal pelvis with a change from your typical hyperechoic center to a more hypoechoic appearance secondary to this increased fluid collection. Also notice that they use Doppler to ensure that this dilation is not caused by vasculature. In this example, you will notice even more dilation of the renal pelvis, with the early dilation of the calyxes and the pyramids as well. Note there is no thinning of the cortex in this example, which is the hallmark of severe hydronephrosis. In this case, you notice there is significant obliteration of the cortex and severe dilation obscuring any of the normal renal anatomy. Also note how all of the fluid appears to communicate. It is sometimes difficult to separate hydronephrosis from a patient with multiple large renal cysts. If you note large circular areas of fluid, which do not communicate, this would be more suggestive of renal cystic disease. Not uncommonly, renal stones can be visualized with ultrasound. They appear as echogenic foci within the renal parenchyma and are rarely symptomatic. Larger stones will produce the typical shadow, which might not be present with smaller stones. Now, as the sonographer pans through this kidney, you can see small echogenic foci with shadowing consistent with renal stones. Placing Doppler flow onto one of these echogenic foci should produce a twinkle artifact, as seen here. Ureteral stones may lead to hydronephrosis if they cause partial or complete obstruction. However, actual visualization of the stone itself is very difficult with ultrasound. Occasionally, a stone can be detected right before entering into the bladder, as seen in this example, with a brightly echogenic foci with the posterior acoustic shadowing. A simple renal cyst is a common finding, often easily seen with ultrasound. To be characterized as a simple cyst, it must be smaller than 10 millimeters, have no internal echoes, have smooth outer walls, and must have posterior acoustic enhancement. Polycystic kidney disease is also readily seen with ultrasound, has numerous bilateral cysts. Here is an example of a renal cyst. Note the posterior acoustic enhancement. This enhancement is an artifact where the region just deep to the cyst appears slightly more hyperechoic or more bright than its surrounding region. This occurs because sound waves are being absorbed or scattered by its surrounding tissue, but readily pass through the fluid-filled cyst, thus allowing increased resolution and penetration to the region just below the cyst. If the cyst was to contain echogenic material such as blood or pus, that material would act to absorb and scatter the sound waves and would not give you that typical posterior acoustic enhancement seen in a simple cyst. Complex cysts have the presence of those internal echoes, which differentiate them from the simple cyst. They also differ from solid masses in that masses will not have the cystic component seen in a complex cyst. Any complex cyst seen on ultrasound should raise your concern for an abscess, a hemorrhage, or cancer, depending on the clinical setting. Note this cystic structure with large amounts of internal echoes, thickened wall, and large in size. This is a complex cyst. After performing multiple renal scans, you will undoubtedly come across a renal mass. The diagnosis of cancer cannot be made based solely on the ultrasound findings. If seen, a patient should be informed of the abnormal findings, and follow-up should be arranged for further testing and evaluation. Ultrasound can be an invaluable tool in the assessment of patients complaining of urinary retention. Calculating bladder volume is done by multiplying the bladder width, diameter, and height in centimeters by 0.6. This will give you a bladder volume in cc's or mLs. Let's now talk about a few pearls and pitfalls when performing the renal point-of-care ultrasound. As mentioned earlier, it does take time for hydronephrosis to develop. Thus, even in patients with a complete obstruction, if presenting early enough, the ultrasound may be negative for hydronephrosis. Make sure you adequately hydrate patients prior to performing the ultrasound, especially if there is associated vomiting or diarrhea with the flank pain. With significant dehydration, the amount of hydronephrosis may be underestimated. Renal and ureteral stones are difficult to detect with ultrasound. In the absence of other findings, further testing may be required. The inability to detect a stone does not rule out a stone. Remember that hydronephrosis is not always due to a stone. Clinical correlation must be used in conjunction with the ultrasound results. In conclusion, point-of-care renal ultrasound is a relatively simple exam to perform. The primary goal is for the detection of hydronephrosis, control patients' pain and adequately hydrate prior to performing the examination, and the use of ultrasound can help minimize the overuse of CT scan in the evaluation of undifferentiated flank pain. If you have any questions, please contact us through eusacademy.com or directly through email at mattlyonmd@gmail.com. Thank you.